Support for this program is provided by CSL Behring, CVS Specialty Pharmacy, and Grifols.
Hello, and welcome to Bold Conversations, an Immune Deficiency Foundation podcast series aimed at advancing knowledge and understanding of health equity. I am your host, Dr. Nicole Rochester, the Immune Deficiency Foundation's medical advisor for health equity and the founder and CEO of Your GPS Doc, LLC. Welcome back to Bold Conversations. You all, we are in season 3, and I'm super excited to bring another amazing guest to this podcast series. Our guest today is Jalisa Clark. She is a research fellow at the Center on Health Insurance Reforms at Georgetown University's McCourt School of Public Policy. Her research includes state measures to improve health equity, federal reforms on health insurance, and monitoring state innovation waivers. And I'm going to have her tell us a little bit more about herself and her work. But Jalisa, thank you so much for being with us today on the podcast.
Thank you so much for having me. This really is an honor. And in my day-to-day life, when I tell people I work in health insurance research, I can see them starting to fall asleep. So I appreciate to have a platform that wants to talk more about health insurance and all that there is to it.
That's awesome. Well, why don't we start there? Because I'll be honest with you, I had not known previously that this was a whole research area. So tell us about your background and what led to your research interest in health insurance reform.
My master's degree is a master's in public health with a specific concentration in health policy and management. And this can look for a lot of people in different. This can look different for a lot of different people. So some people go to work in the hospital system. Some people want to do general public health. So think about um, campaigns for vaccination. A lot of people go into policy, and my interest was in policy, specific health policy systems, so healthcare systems in the US. And basically what it boils down often here is insurance. So who is paying for your health coverage? How much do they pay? Who is covered? How much of your health care is covered? And I think my big interest in that drew from at the time was, I think this is 2017. The big conversation, the big topic was Medicare for all. And we saw in this country in a way that we haven't seen in a while, the people wanting the government to pay more for healthcare, people being upset with their insurance, feeling like they're paying for a product and that product was not delivering. And so when you have these conversations for Medicare for all, you're like, what does that look like? How much is gonna be paid? Who's gonna be covered in this? Like what are the networks gonna look like? And so that's where I kind of got interested in. And still, those are the same questions that are being asked today. So what services are being covered? How how much should these services be covered? And what do the processes look like? Is it before deductible? Is it after deductible? Do we need bigger networks, tinier networks, and basically all the kind of the nitty gritty and what benefit design works best for people? Because you want an assurance that people want to use. Oh yeah.
Absolutely. As you were talking about like deductibles and co-pays and things, I'm reminded, in my work in health advocacy, I do a lot of education around just basics of health insurance. And as I'm sure you know, so many people are not aware or familiar with the terms and they don't understand the benefits. And even, this is regardless of education. There's just so much lack of information, I think, and lack of knowledge with regard to how health insurance works. In preparation for this conversation with you, Jalisa, I did a little research just looking back on the history of health insurance. And I thought it might be helpful for us to share a little bit about that history with the listeners, because, for those of us who were maybe born in the last 30, 40, 50, 60 years, we may not have a full understanding of how health insurance came into play. Like you said, we're familiar with some of the recent reforms or attempts at reform. But as I reminded myself of the history, it was very fascinating to learn that, at least according to what I read, and you can correct me if I'm wrong, that health insurance really kind of originated in with the military and with the Marine Hospital Fund. Apparently, this is in the late 1700s that there was a Marine Hospital Fund that was financed through a tax on the pay of maritime sailors. And then we started to have in 1850 the Franklin Health Assurance Company of Massachusetts, which was kind of the introduction of accident insurance. And then there's kind of this slow, steady progression of from accident insurance to finally, hospital insurance or insurance that actually pays for medical expenses. And then that moving to like Blue Cross and kind of the introduction of Blue Cross. And then that ultimately moving into employer sponsored plans, which I think wasn't until after World War II. And then, of course, the big addition of Medicare and Medicaid in 1965. But just this idea that originally, there was a time in our history in America where people were paying all of the costs of their medical care out of pocket, fee for service, and I guess paying it however they could. And of course, that created a situation early on where there were inequities with who could afford to pay and who could not afford to pay. And then even now that we have um, the employer-based insurance, what I have seen in my work is that there are still a lot of inequities in that who has, quote unquote, good employer insurance varies. There are people who work and even work full time who either don't have coverage or don't have appropriate coverage. But based on your extensive work, your experience, your research, what would you add to that history about health insurance in a way that maybe provides some context for how we got where we are now?
No, I think that was a great background, a great history, and I'll jump in right here. You were talking about employer-sponsored insurance, and I think what is really, really hard is something that we need to remember is that the landscape of insurance today looks drastically different because of the Affordable Care Act. Okay, so the Affordable Care Act instituted so many wide sweeping changes to the landscape of insurance today. So it allowed young people to stay on their parents' insurance until 26. I mean, I think in the first year there was like a 1 to 3 million deduction in uninsured people who were uninsured because of raising that young adult availability to stay on your parents' insurance. Then, of course, there are the pre-existing conditions, which I can talk a little bit later, but basically, insurers were allowed to flat out deny if you've had a pre-existing condition. And I think that actually one of the things that I find myself doing because I work in insurance, as I'll throw out a term, pre-existing condition literally means that at some point in your life, within that you had been diagnosed or you were seen for a medical issue. So, and I mean, that stays with you. If you go to the doctor says, oh, your blood pressure is high, and that's in your medical records, you now have a pre-existing condition, which is high blood pressure. And based on that, for the rest of your life, insurers were able to charge you more for coverage or flat out deny you for coverage. So it's a crazy landscape there. And then tying to employer-sponsored insurance, the ACA made it so that if you were an employer who had 50 or more full-time employees, you had to provide insurance to those workers. And it had to be affordable. So it had to be around, I think today it's like the premiums can't be more than 9% of their wages, and it has to have a certain amount of coverage available. So those are three huge changes that don't even have to do with the actual setting up of healthcare.gov and the actual marketplaces where people can buy individual plans. And what I think is really interesting that we, as the United States, cannot seem to get away from is the kind of the general inequities a part of employer-sponsored insurance. So, as you were saying, in the modern health insurance system, it stems from companies needing to provide a benefit to workers that wasn't more pay. And so that's where insurance comes from. So it's not directly money in your pocket, but they're like, we can provide you this benefit. It stemmed from providing coverage to able-bodied white men workers and typically working union jobs. So this excludes insurance coverage for those who are unable to work. This typically is building off of looking at industries where women aren't working. And then there are also racial and ethnic divides. And what's really interesting is that if we look just back into the 90s, so this is a study that's looking at 1999, this is before the ACA, and they found that there were disparities among full-time working adults who were less likely to have employer-sponsored insurance by race and ethnicity. So they looked at union workers, and 91% of white union workers had employee-sponsored insurance compared to 86% of Black union workers. And that's something that you have to think about is like, how are we in these? You're in a union and we're seeing disparities. And then, of course, when you look at non-union workers, there's even greater disparities in employer-sponsored insurance. So in 1999, 75% of white non-union workers had health insurance through their employer compared to only 52% of Hispanic non-union workers. When I was talking about the importance of the ACA requiring employers with 50 or more full-time employees, the importance of offering them coverage, you saw that in 1999, they looked at employers that had 100 to 1,000 workers, and they found that in those large firms, 84% of white workers had employer-sponsored insurance compared to only 68% of Black workers that had employer-sponsored insurance and 61% of Hispanic workers. So there are just disparities abound in the employer-sponsored insurance. And that's why I think conversations where when we ask what kind of healthcare system can we build that is more inclusive to race and ethnicity, more inclusive to those whose um, disability doesn't allow them to be a full-time worker, what does that look like? And in the meantime, what kind of insurance can I buy, not from an employer? Ideally, you want a marketplace, an ACA plan, and what ACA plan will be affordable? What ACA plan can I understand? Can I get the most benefit from? And that fits my needs. So that is looking at if you already have a doctor, you want a plan that already has your doctor included in the network. Depending on where you live, if you have a hospital that you prefer to go to, looking for a plan that has that hospital in network.
Wow, thank you, Jalisa. That was phenomenal. As you were talking, it was just reminding me of all of the protections that we have as a result of the Affordable Care Act, and also just, there are a lot of critics, as I'm sure you're aware, of the ACA. And as with many things, there's often a lack of recognition. There's this misconception that only certain people benefit from certain laws. And these were wide sweeping reforms in the insurance industry. And I want to point out on a personal note, as someone who owns her own business, when I left medicine and started working for myself, I had to get a plan. And all those protections that you mentioned have benefited me and my family, my ability to purchase health insurance for myself without, regard for, like you said, pre-existing conditions, not only in myself, but in family members. I have young adult children, both of which at various times have been on my health insurance. So the ability to keep your young adult child on your insurance up until age 26. All of those things are so incredibly important. You look like you
No,
want to say something.
yeah, no, it's incredibly important. And with the new administration, you have to look back at what they did in the past and wonder if they're going to try that again. And in 2017, there was a big push to repeal the ACA. And the Center for American Progress, they did a study, they did an estimate saying like what would happen if the ACA is repealed, and specifically what would happen to the cost of insurance premiums if that pre-existing condition, so that protections allow prohibiting insurers for raising your premiums because of your health conditions goes away. How much would that cost? And so what they did is they looked at a 40-year-old person They did this based in 2020. The study is in 2017, I'm pretty sure, and they cast it forward to 2026. And they say that the base premium they estimate as 6,000 a year, right? So they're saying that's the base premium with protections. And then what they do is they look at other conditions and they try to estimate how much more, what would be the surcharge because of for your premiums based on your conditions. And this isn't an issue. This isn't something like, oh, this would only impact those who are low income. This is not even something that would only impact low income and middle income families. This is the range that this of it would affect every single person in America. So one of the things that they estimated that if you had breast cancer in the past or current, your premiums would increase. So on top of this 6,000 would be $28,000 for the year. $28,000 for the year. If you have asthma, so something that people have their entire lives, your premium would be $4,000 extra. So on top of the 6,000, $10,000 for from one person 40 years old with asthma. Major depression and mental health is an issue we're constantly dealing with this in the United States. That would be an extra $8,000. So like this is expensive. It doesn't, people do not have the money to just pay $14,000 a year in your insurance premiums because you struggle with a mental health disorder. These are the protections of the ACA. This is how big they are and how wide sweeping they are. And something yes, you're right, the ACA does not get enough credit for specifically the pre-existing conditions and how much money it is saving Americans. When premiums go up, the result isn't that people pay them, right? As I just said, like if $14,000 a year, you're not paying that because you're just not buying the insurance. And so then you're uninsured. And so currently, the US is at a historic low for the uninsured rate. So I think it's like 20 million. I think that's about 8% of people are uninsured right now. That's so low. And the number one reason why people continue to be uninsured is because they're sensitive to price. And this is prices with the ACA in place. This is prices where there are subsidies available on the insurance marketplace. I think, oh, I think was it last year they were touting that 4 out of 5 people who purchased insurance on the marketplace were able to get coverage for less than $10 a month. So like there's a lot of financial assistance right now for insurance.
Jalisa, as you were talking about these protections and the forecast for what will happen to our premiums in the United States if indeed these protections go away, I couldn't help but think about the primary immunodeficiency community. And, these are lifelong conditions, many of which require very expensive medications and infusions. And I can't even imagine the cost that members of this community will be faced with if the ACA is repealed and they are now subject to these additional costs related to their pre-existing conditions. Like this is untenable.
It's hard to imagine that things could be worse than they are right now because, I mean, the problem is today, the reason why people are so frustrated is because insurance right now doesn't provide enough coverage. And what's really interesting is that people are adding this word underinsured into the conversation. So there's uninsured, which is just straight up there's no other provider paying for health coverage. And then there's underinsured. And so these are people who have insurance coverage, whether through their employer, whether through the marketplace, Medicare, Medicaid, but are still struggling to access care because the out-of-pocket costs are too high. Their deductibles are too high, so they are having to front, the cost into the thousands before their insurer steps in or before they can access, get a copay or co-insurance. This is a major problem, and it's a huge issue for those with chronic conditions, those who have to access these treatments, have to get X-rays, have to get tests and lab tests and diagnostics. All these costs add up, and it comes it's paid by the patient into the thousands once again before the insurer steps in. One of the ways that we're seeing on this was one of the big things in the Biden administration to kind of combat this was standardized plans. So standardized plans, these are found in the marketplaces. So the healthcare.gov, as well as the different states that run their own exchanges. We call those state-based marketplaces, SBMs. And what standardized plans are is it's a set of cost sharing standards. So for every insurer, whether it be Cigna or Blue Cross Blue Shield or Kaiser, they have to have the same exact cost sharing for each plan by their metal tier, so bronze, silver, gold, platinum, with it getting more generous as the metal tiers go up. And so the way that this looks is that whether you're purchasing from Cigna, whether you're purchasing from Blue Cross Blue Shield, you know that if you buy this, let's say silver tiered plan, you're gonna have a $10 copay for your generic drugs. And then it's going to be maybe perhaps a $40 copay for x-rays. And so with that set in stone, knowing that this is going to be the same across issuers, then you can look at other things that the plans offer and make your decision based off that. Once again, whether your doctor's in plan or whether you just had a good experience, calling customer service from this plan. And it allows you to, it takes, with something standardized, it allows you to look at other things that impact your health care and make your decision based off that. What's really interesting and what we're seeing a lot in standardized plans are co-pays before the deductible. Just for a reminder, deductible is how much you have to pay before your insurer kicks in. So let's say you have a $4,000 deductible and you have a $20 copay for outpatient specialized care physician visits. So you would have to pay $4,000 in medical care before your insurer says, okay, now you just have to pay that $20 to see this outpatient physician, which, I mean, that's insane. It feels like madness. You're telling me I have to spend $4,000 before I just have to pay $20 to see my doctor? It feels like a ripoff, and then it feels why people are. You can understand why people are frustrated with your insurance. So what we're seeing is this trend, and in standardized plans of putting more co-pays before the deductible. So you're seeing, okay, your deductible is $4,000, but for this outpatient service, we're going to allow that you just have to pay $20, that $20 copay for this service before, and you don't have to reach the deductible. What that does, it makes it more affordable for people to show to the doctor's office. It makes people fine. They're like, fine, if I know that if I'm from the start, from the moment I'm covered, I just have to pay $20 to see this, specialized care physician, I'll go. And so that's one of the great things about standardized plans, and that's one of the ways of working insurance. So that people who are insured don't feel like they're uninsured. They feel like they're still getting some benefit from the start without meeting their deductible.
Thank you for explaining that. And as you were talking, it sounds like, well, one, I will say I have noticed that myself, because again, I continue to purchase my insurance through the ACA. And so I have definitely noticed each year that there are more co-pays that are covered before my deductible, which has made me very happy as a healthcare consumer. But as you were talking, Jalisa, I feel like this is also a measure, going back to kind of the equity conversation, that improves or facilitates equity within the health insurance space. Because when you have a situation where your deductible is your deductible, $4,000 as your example, there are some people who will be able to afford that $4,000 deductible, although it might be a sacrifice. And there are other people who just absolutely cannot. And so if we look at, health inequities, if we look at marginalized populations, if we look at Black and brown people or people with physical or mental disabilities, people who historically have income inequity gaps and all of these things we can understand, or people that maybe don't have a trust fund or money that was passed on to them from their wealthy parents, you can see how that's a situation where you have this have and have not, where somebody can afford this $4,000 deductible and someone else is making the decision between going to the doctor or paying their rent or putting food on the table for their children, which we know are real conversations even now in the US. So in addition to these standardized plans, what other ways have states addressed insurance inequities?
Yeah, so one of the ways we see that is that states are kind of building on to standardized plans. And one thing that we can see from states and state-based marketplaces so that are designing their own is that people enrolling in the marketplace, they are buying into these plans. They're with an option of having a standardized plans or a non-standard plan. We're seeing that they're buying the standardized plan. So Washington State, their standardized plan is called the Cascade Care. And their last open enrollment, 73% of people who enrolled through Washington um, marketplace purchased a standardized plan. So 73%. That's huge. That's a great success for Washington. And one of the things that Washington is trying to do is they're trying to be mindful of affordability. So really kind of looking at, once again, looking at the services pre-deductible and deciding what are people using the most and what would be most beneficial for them to address. You've also found that in Connecticut. So Connecticut, one of the things that they've reached and looked at in their standardized plans is looking at lab costs and really trying to lower the cost sharing for lab tests and services with services for patients with keeping in mind and really prioritizing those with chronic conditions. Now, DC, they're super interesting, and I'd give them credit with really elevating what was being called equity-based design. So equity-based design is looking at current healthcare conditions where there's a disparity in the outcome by race and ethnicity. So one of the examples of this is diabetes. Diabetes is an issue that all of America is dealing with. White, Black, Hispanic. It is just it's a chronic condition that many Americans have. But when looking at the data, DC found that it was Black Americans who were having the worst outcomes from diabetes. And so what they did is they wanted to increase access to healthcare by lowering cost sharing in their standardized plans. So one of the first things they did was they required in their standardized plans for everyone who's enrolled in this plan and has type 2 diabetes, zero cost sharing. So $0 for a preferred brand insulin, some select non-insulin injections. They also added with it unlimited primary care office visits, and nutritional counseling visits. They had an annual retinal and diabetic foot exams. They basically sat down with experts in diabetes care and said, what would a person need for a year to manage their diabetes? And they took all those services, took those medications, and put it before the deductible, and lowered cost sharing for most, but also then made it zero. So that's huge. And then DC didn't stop there. So then they saw in the youth population that young African American children were really struggling with mental health. And they set a $5 copay before the deductible for outpatient mental health visits. And then in this new year, so coming in plan year 2025, they also added services and drugs related to cardiovascular disease. Also, another disease with disparities in outcomes by race and ethnicity. What is interesting, and I think that needs to be noted, this is all under the umbrella of equity-based design, but it applies to every person in that plan with these conditions. And I think that's what's so kind of important about America is like, yes, it varies in the severity and in the prevalence by race and ethnicity, but these are conditions that we all have, and these are conditions that all Americans are struggling with. Diabetes is a huge conversation, and that's why you saw with the Biden administration, them limiting insulin for $35 in Medicare. You could call that an equity-based design,
Yeah.
right? it was sure diabetes was impacting all the Medicare population, but I'm sure the studies will show that there is disparities in outcomes by race and ethnicity. So that's what this equity-based design approach is, and it's very interesting because it asks the question, what would I want my insurance to cover if I had this, or if I had this condition and I could design it, what would I want?
Well, you explained that so well, and I want to just highlight what you already highlighted, but I just want to put a double line under it, highlighter for everybody listening, because it's this idea of equity, which is really, the core purpose of this podcast series is to really educate our listeners about equity and to help everyone understand that when we make these equity-based designs, when we implement things, whether it's policies or systems or even laws, to help an individual or a group who historically has been marginalized, everybody wins. And so as you were talking, I was reminded of an example that I have used in some of my presentations. So I'm reminded of legislation, and I don't know the year, but that mandated access just with regard to like sidewalks and curbs and ramps, and how there was a time where there were no cutouts, there were no ramps. So you had to step up from the street to the curb, from the curb to the street. And as a result of legislation and making things accessible to those with physical disabilities, originally meant for wheelchairs, it benefited everyone. As someone who, now my kids are adults, but when my kids were young babies and I had a stroller, I regularly would look for that opening in the curb so that I could roll their stroller, over that ramp. And even ramps that give you access to buildings. And there are so many other uses. If you're traveling and you're pulling lots of luggage, being able to just be able to find that opening and pull your luggage up on that ramp. So I use that example just as a very practical case where we can hopefully see that when there are laws that are implemented, when there are policies that are centering individuals with maybe a specific need, we, number one, the rest of us don't lose. Like, it's not like they gain, we lose, but also we gain too, because many times these interventions end up helping all of us. I don't have diabetes. Thankfully, I don't have any chronic conditions at the time of this recording, and I am able to benefit from all of those things that you mentioned. I'm able to benefit from having co-pays that kick in before my deductible. So I just really wanted to highlight that, because we know that sometimes there is rhetoric around this idea that equity means that somebody's losing, and it really is a win-win.
No, it's such a win-win. And we could talk about costs, right? Hospital costs are some of the biggest drivers for your insurance premium. So I guess when we as a collective spend more money and more time in the hospital, our premiums go up. So, but also there's also the cost of life, right? So we want people to be able to go to the doctor. We want people to manage their conditions so that they can stay alive, but also we want them to have a better quality of life. And that requires people being able to manage their conditions, like not feeling as though they have to wait more time to see a doctor because of the cost of it, not having to split medications or deciding to go without a test for a month. We want people to be able to manage their conditions safely and efficiently, and that it saves everyone money at the end. What's really interesting is that HHS, they propose this idea that would allow insurers to design non-standardized plans, but plans tailored for specific conditions, if they could demonstrate that the way that they design their plan would save those with that kind of condition 25% or more in their cost sharing. I think this stems from one insurer, Oscar Health, which had designed a insurance plan around diabetes in which they lowered the cost sharing for diabetic foot exams as well as wellness programs and health coaching. As much as I do like this idea, one of the things, and you kind of mentioned it, is that everyone needs access to care. So we really kind of have to work on the fundamentals of health insurance, which is everyone feeling as though they can go to the doctor before we can tailor these kind of specific programs where at the end of the day, someone could purchase that specific insurance and it doesn't cover the other things that they need. So in a standardized plan, when we're adding these benefits, you still have access to a primary care office. You still have, a set cost sharing for an ER visit. When the plan's not standardized and it has a name like, something like diabetes, you may click on it thinking that it covers everything that you need, but it may be missing on other areas because just because you have a chronic condition doesn't mean that there can't be another unexpected health condition that arises that year. So we want to make sure that people are getting tailored insurance, but also being protected in general for any other health insurance or issue that may arise.
That's a really good point. It's a really good point. There's so many opportunities for education and, health literacy as it relates to insurance. With regard, as you talk about these standardized plans and these plans that are tailored around conditions, people with primary immunodeficiency have rare conditions. And so it makes sense to me that there are plans that are being tailored around diabetes or around heart disease. But for the person listening who maybe they or their family member or loved one is managing a rare disease like a primary immunodeficiency, do you see any opportunities for health insurance reform in that area?
I can't really speak towards health insurance reform. I mean, there are some basic things like as we were talking about earlier about in Congress making sure that we keep in premium subsidies, issues like that, keeping the ACA in place. I think on an individual level, when picking out insurance, for people with chronic conditions, I think maybe perhaps one of the number one things to look at is the network and making sure that your doctor is in your network. And honestly, the US has a long ways to go there. Provider directories are not readily available. And when they are, they're not up to date. It can be really hard if you're shopping for insurance to know which insurer covers your doctor. And sometimes the only reliable way is to call every single one of your doctors and ask them whether they take this insurer, whether they take this plan. And that's one that's very timely for the person making the call, but it's also the doctor's offices don't have the time. And as someone who's done this myself, feel like they do not have time for me at all to be answering my questions. Um, so yeah, I think that is one of the main issues, one of the surprises that patients can face when they go to a doctor that they've been seeing their entire, for the past couple of years, and they find out for this one year that this doctor is no longer in network, no longer covered, and their copay's gone up. Every state has a Department of Insurance, and that Department of Insurance is supposed to help you fight an insurance claim denial. That's what they're there for. And I feel like a lot of times people, they'll get a denial back from their insurer and feel like that's where the buck ends. They can try to appeal it within their insurer. You can go to your Department of Insurer. That's what they're there for. And there's an organization, it's the NAIC, it's the National Association of Insurance Commissioners. I've been to a lot of their national meetings. They constantly are trying to think, how can we get the word out to people? How can we get the word out to constituents that we are here? This is I'll plug them right now. Your state has a Department of Insurance, whether it be your employer sponsored insurance, whether it be a private insurer, you should go to them if you run into a problem, specifically, especially if it's a service or medication that you've had covered before and it's being denied now. Even if not, talk to your Department of Insurance because if not, they can steer you in the right direction and tell you the next course of action. I will say once again, it's tough because that takes time. And when you are sick, you don't have time and you definitely don't have energy. And I mean, sometimes this process can go on for weeks. So if it was urgent, um, then that really puts it's not the resource that you need. But I would definitely encourage people to reach out to their state's Department of Insurance.
Now you just taught me something, Jalisa, because I'm not aware. I wasn't aware that every state has that. So that's very useful information. This has been incredible. I have learned a lot about health insurance and about reform and equity-based design. I'm sure the listeners have as well. Is there anything that you want to leave us with? Any closing thought regarding this work or your research before we say goodbye?
I think I will say is that insurance really brings everyone together. Everyone needs to be in the risk pool. Everyone needs to be contribute. When we contribute our premiums, it goes to the person in need then, and then down the road we could be the person in need. It's such a communal aspect, and so when we're having these kind of conversations nationally, I think it's just a one thing to focus on is that it doesn't matter your economic, so your status, it doesn't matter your race, ethnicity, your gender orientation. When you are sick, you need health coverage. And health insurance is one of the best ways that we can make sure that everyone is covered and able to financially access the health care that they need. So, yes, I just wanted to continue to be health insurance to be a national conversation. And I want it to be a topic where we can all agree upon that the system that we have now, as though much better than it was before prior to the ACA, there are so many opportunities to strengthen it and so many ways that we can make healthcare more affordable.
Wow. Thank you so much, Jalisa. I really appreciate you being on the show and sharing all of this information with our audience. Is there a way that people can contact you if you have, I don't know if you're on social media or if they wanted to read the articles that you've written about this topic?
Yes, so if you Google my name, Jalisa Clark, also with Georgetown University Center on Health Insurance Reforms, we're a research center with Georgetown University that writes on every aspect of private insurance. And I will tell you that it is actually ridiculous how many things that go on in private insurance that impact our premiums and deductibles and our networks. So there's an array of information there. You can also follow me on Blue Sky. I've made the jump at Jalisa, Jalisa Health, to reach out. And feel free to email me with your insurance questions. I do it for my family all the time. I'm as someone who has been in this field for years, I still struggle with my own insurance and getting with my walking out of an eye exam and finding that something wasn't covered. I tell you, the system is not easy to navigate. So feel free to reach out to me if you have any questions.
Thank you so much, Jalisa. And you all, thank you for listening. We have lots more exciting guests and so much information for you in season 3. So I'll see you next time.